Good afternoon. I'm Kelly Waters, a Senior Health Communications Specialist on the Emergency Partners Information Connection team in CDC's Center for Preparedness and Response, Division of Emergency Operations. Thank you for joining us for today's EPIC webinar titled Ebola in Democratic Republic of the Congo. Today we will hear from Ebola experts in CDC's National Center for Emerging and Zoonotic Infectious Diseases. If you do not wish for your participation to be recorded, please exit at this time. You can earn continuing education by completing the webinar. Instructions on how to earn continuing education can be found on our website, emergency.cdc.gov/EPIC, EPIC. The course access code is EPIC, EPIC 0619. With all letters capitalized. To repeat, the course access code to receive continuing education units is, in all caps, EPIC 0619. Today's webinar is interactive. To make a comment, click the chat button on your screen and then enter your thoughts. To ask a question, please use the Q&A button. The Q&A session will begin after our presenters finish. Closed captioning is available for this webinar. The button to enable this function can be found either at the top or bottom of your screen. We're fortunate today to have three experts with us. Dr. Mary Choi is a medical officer with CDC's Viral Special Pathogens Branch. She graduated from George Washington University's School of Medicine in 1999 and completed her residency training in emergency medicine at the University of Michigan. In 2010, she completed a fellowship in international emergency medicine at Columbia University, where she also received her Master of Public Health degree. She graduated from CDC's Epidemic Intelligence Service in 2014. Mary has deployed to the Democratic Republic of Congo multiple times in response to this outbreak. Mary will discuss the status of the current outbreak. Shah Ruhi is a Senior Advisor for Preparedness and Response at the Division of Global Migration and Quarantine. He is a registered nurse with a Master of Public Health degree and has 30 years of experience in the health field. Shah's areas of expertise include ill traveler management, quarantine, isolation, and public health preparedness. He has served in various roles during previous CDC responses to outbreaks of Ebola, Zika, MERS, and the H1N1 influenza pandemic. He is currently managing his division's border health response for the 2018 DRC Ebola outbreak, and also supports other emergency preparedness and response activities. Shah will discuss recommendations for organizations sending US-based healthcare or emergency response workers to areas with Ebola outbreaks. Trevor Shoemaker is a senior epidemiologist with the CDC's Viral Special Pathogens Branch. He currently focuses on enhancing surveillance and outbreak detection for viral hemorrhagic fevers internationally. He previously served 6 years as Program Director for the Viral Special Pathogens Branch in Uganda. He has been working in infectious disease epidemiology and public health for over 20 years. Trevor will help answer questions during the Q&A session. Thank you, Shah, Mary, and Trevor for joining us today. Mary will be our first presenter. Mary, please begin.
Hi, so thank you for that introduction. Next slide. Ebola virus disease is a rare and deadly disease caused by infection with one of the 6 viruses within the genus Ebola virus, and they are listed here. Next slide. Of these, the ones highlighted in red are the ones that have been known to cause disease in humans. Next slide. Reston virus was isolated in monkeys that were being held at a monkey quarantine facility in Reston, Virginia. Bomboli virus is the newest of the viruses in the group and was detected in bats in Sierra Leone. Next slide. Since its discovery in 1976, there have been 28 outbreaks of EBD. The current outbreak is the 10th in the Democratic Republic of Congo. The natural reservoir host for Ebola viruses is unknown, but bats are the most likely reservoir. Next slide. This is a depiction of how a virus in a bat can infect humans. In bats who carry the virus, bats can spread the virus in their saliva, in the urine, and in the droppings. Uninfected bats can then become contaminated through contact with these infectious fluids. Bats can then transmit the virus to humans in several different ways. Number one, humans can be contaminated through direct contact with with the secretions of the bat. So either through a bite or being exposed to bat feces or urine. The other possibility is sometimes people will butcher bats for food, and then humans can be contaminated in that manner as well. Humans can also be infected through intermediaries, such as monkeys. So how does this happen? So a bat who is infected with the virus can feed on fruit. The fruit is then eaten by animals who then become infected by eating the contaminated fruit and then become ill. Hunters can then catch these animals because they are sick and easier to catch. Next slide. Ebola virus can be found in all bodily fluids of someone who's contaminated with the virus. So it could be found in the blood, the feces, vomit, urine, tears, saliva, breast milk, amniotic fluid, vaginal secretions, sweat, and semen. The virus is transmitted through contact, either through a break in the skin, eyes, mouth, or mucous membranes with body fluids of a person who is sick or died of Ebola. Next slide. A person infected with Ebola virus is not contagious until symptoms appear. The signs and symptoms of EVD include the following, and they're listed here. Bleeding is a rare finding in Ebola and happens in less than 50% of cases, and is a late finding. As you can see, the signs and symptoms of Ebola are pretty vague and can be seen in many other diseases that are endemic in Africa, such as malaria and typhoid. The lack of pathognomonic signs and symptoms is one of the reasons why Ebola virus is so difficult to diagnose. Next slide. So now that we've talked about the signs and symptoms of Ebola, let's talk a little bit about the progression of symptoms. So following infection, the first period is the incubation period. During this period, the person has no signs and symptoms of Ebola, and they are not able to transmit the virus to anybody. The incubation period lasts between 2 to 21 days, but on average lasts between 8 to 9 days. Following the incubation period, the first symptoms that we will see are what we call dry symptoms. And these are symptoms such as fever, headache, body aches. At this point, with the development of signs and symptoms, the patient is contagious and can transmit the virus. Following that, on or about day 4, patients will develop what we call wet symptoms, such as vomiting and diarrhea. At this point, the patient is very contagious, and the vomit and the diarrhea has very high levels of Ebola virus. Without treatment, death occurs about 7 to 10 days after illness onset. And at the time of death, the amount of Ebola virus in the body is at the highest. So when you look at this spectrum of disease, what's important to realize is that in order to stop transmission in the community, patients need to be isolated before the onset of wet symptoms. Next slide. There are no FDA-approved treatments for EVD. Studies have shown that early supportive care alone can significantly improve the chances of survival. There are 4 experimental treatments approved for use in the DRC through a randomized clinical control trial, and they're listed here. Both ZMapp and remdesivir were used successfully in the 2014 West Africa outbreak. MAB-114 is a monoclonal antibody that is actually developed in collaboration with the Democratic Republic of Congo. And that antibody was actually found in a survivor of the 1995 Pickwick Ebola outbreak. Next slide. there is a vaccine that's currently being used in DRC. The vaccine is a live vaccine that contains a piece of the Ebola virus. Because it only contains a piece of the virus, vaccination will not cause someone to develop Ebola. The vaccine is experimental and is given as a single dose. The other thing that's important to remember is that this vaccine protects only against the Zaire species of Ebola virus. Now, in someone who's already been infected and is incubating, this vaccine will not prevent them from developing the disease. However, some preliminary data has shown that individuals who are vaccinated and subsequently develop Ebola are more likely to survive than those individuals who are not vaccinated and develop Ebola. Next slide. Currently, the vaccine is offered to contacts and contacts of EBD cases through a ring vaccination strategy. Frontline workers are also eligible for vaccination. Eligibility criteria for the vaccine include children 6 months of age or older, and adults to include pregnant and lactating women. So when I say ring vaccination strategy, what does that mean? So after a person is diagnosed with Ebola, the response team will talk to the patient and find out everyone that they've had contact with while they were ill. These contacts will then be offered vaccination. Then the response teams will talk to the contacts and identify who their contacts are. And then these contacts of contacts will be offered vaccination. Next slide. On August 1st, 2018, the DRC Ministry of Health confirmed an outbreak of Ebola virus, species Zaire Ebola virus, in eastern Congo. On June 12th of 2019, Uganda reported 3 cases of EBD in returning travelers from DRC. As of June 16, 2019, EBD cases have been reported in 22 health zones in the Democratic Republic of Congo. This makes it the second largest EBD outbreak in history and the largest EBD outbreak ever to have occurred in the Democratic Republic of Congo. Next slide. As of June 16th of 2019, a total of 2,168 cases have been reported and 1,431 deaths. And a total of 119 healthcare workers have been infected. Next slide. The DRC Ministry of Health is leading response efforts in assistance with the local international partners, including the WHO and CDC. Response activities are divided into pillars to include the following listed below. I'll touch upon a few of these to kind of explain what they are. So the surveillance pillar is responsible for investigating cases and determining epidemiologic links between patients. They're also responsible for contact tracing. Point of entry is responsible for screening travelers at both land and water barriers, as well as at airports. The psychosocial and community engagement group is responsible for interfacing with the community, developing messaging, as well as supporting family members of suspect and confirmed cases and supporting survivors and helping them integrate back into society. The safe and dignified burial teams are responsible for testing bodies for EBD and then safely burying those who have died of Ebola. And the case management pillar, they're responsible for management of patients inside Ebola treatment units, as well as transit center, which is where suspect patients are being cared for. Next slide. So the current outbreak is occurring in the setting of a complex humanitarian emergency. This area is a mineral-rich area and has been, and there are many rebel groups in the area who have been fighting for control because of this. This has led to over 1 million internally displaced persons in DRC alone, as well as continuous movement of refugees to neighboring countries, including Uganda, Rwanda, and South Sudan. The response has also faced incidents of violence against response teams and pockets of community resistance. In April, a WHO epidemiologist was killed. In addition, there's a lot of mistrust between the community and response workers. There is a rumor that Ebola is not real, and they feel that it's a pretext to just generate money for international partners. In addition, Ebola has been used by politicians. So in the last elections in December, voting was actually canceled in the affected areas. The reason that was given was that they were concerned that by holding elections, that would contribute to the spread of the disease. But the community felt that it was actually just a move for mass voter suppression. All of these factors have led to a high number of EBD deaths occurring outside an Ebola treatment unit and a low number of confirmed cases under surveillance at the time of notification. Next slide. The US government, including CDC, is working with the DRC, Ministry of Health, and other partners to provide technical assistance in the areas that are listed here. I'll touch upon a few of our activities. So CDC has embedded with the surveillance teams to help them analyze the epidemiologic data. We've also embedded with a data analysis team that's situated in Goma, DRC, and we've been working with them to analyze the data to ensure that the data analysis is used to guide response activities. The infection control team at CDC has been working very closely with the Ministry of Health and other partners to develop standard operating procedures for infection control and to assess infection control at healthcare facilities. And our communications team has been working very hard along with the Red Cross to analyze community feedback and to develop messaging based on that feedback. As of June 11th, 187 CDC staff have completed 278 deployments to both DRC, Uganda, South Sudan, and Rwanda. We've also deployed to Geneva to support the WHO operations there. Next slide. On June 13th, CDC activated its Emergency Operations Center at a level 3, the lowest level of activation. This allows the agency to provide increased operational support to meet the outbreak's evolving challenges. Next slide. So as this outbreak continues, healthcare workers and hospitals will continue to see returning travelers who are ill. Healthcare workers should first contact local and state health departments for assistance on assessing a patient for Ebola. CDC have references on our website to help with this, and one of the links is listed here above. Thank you, and now I will hand it over to my DGMQ colleague.
Hello, everyone. Thank you, Mary. This is Shah Ruhi. I work for the CDC Division of Global Migration and Quarantine. Thank you for the opportunity today to speak with you a little bit about border and travel health activities involving DRC and the Ebola outbreak area. First, let me start by saying our hearts go out to the people and communities in the eastern DRC region impacted by Ebola. And also those in Uganda, in a community about 15 miles from the border affected by an imported case of a cluster of 3 cases in a single family. We are thankful to the Ministries of Health and international partners for their heroic efforts and close coordination on the public health emergency response efforts to the Ebola outbreak. As was mentioned a little bit earlier, this is the 10th Ebola outbreak in DRC since the virus was discovered in 1976 in that country. The current outbreak was declared about 10 months ago. DRC has had interim successes while facing ongoing difficulties. The outbreak has occurred in an area of intractable conflict among multiple armed groups at a given time of contentious national elections, as Mary mentioned. To help control this outbreak, CDC has deployed staff for the Ebola response to DRC and for Ebola preparedness in Uganda and surrounding countries. Ebola preparedness and response activities have been comprehensive. They include assisting with planning or undertaking disease tracking, case investigation, contact tracing, case management, safe burials, community engagement, and social mobilization. Other activities have included communication and health education, behavioral science, laboratory testing, border health, data management, preventative vaccinations of healthcare workers, and logistics. The current epidemic is serious, but for context, it is smaller than the West African Ebola epidemic of 2014 to 2016 by an order of magnitude. Let me explain. The former West Africa outbreak caused more than 28,000 Ebola cases. Each of the countries involved in that outbreak had more cases than DRC does today. For example, back in 2014, Sierra Leone had 14,000+ cases. Liberia had 10,000+ cases, and Guinea had close to 4,000 cases, about 3,800 cases. These case counts are attributed to the former West Africa outbreak in between 2014 and 2016. Fast forward today, we have more familiarity with the disease now than we did back in 2014 to 2016. Previously, the international community had fewer intervention tools to work with. And at that time, the research was just beginning to test Ebola vaccines and other candidate drugs in humans. The Merck vaccine now is being successfully used in ring vaccination programs in DRC and has also been used for vaccination of healthcare workers in neighboring countries as a preparedness measure. DRC is a very large country geographically. For context, it is about 2/3 of the size of Western Europe or 1/4 of the size of the United States. And the current outbreak area in DRC is about 2,000 miles from Kinshasa, where the majority of travelers to the US transit from. There are no direct flights from DRC to the United States, and the number of travelers from there to the US is small. Population movement mapping and identification of high-risk areas has informed a coordinated effort to screen travelers at points of entry and exit and internal points of control in DRC. There is exit screening at the Goma airport and entry screening in Kinshasa for those arriving from the outbreak area. From the beginning of this outbreak, DRC has screened more than 67 million travelers at points of entry and exit and points of control. This averages to more than 200,000 travelers or more a day. US-bound Congolese refugees undergo a 21-day mandatory surveillance period that includes daily health monitoring checks in a transit center prior to departing for the United States. WHO's assessment of the situation is that the risk of spread nationally in DRC and regionally is high. However, the risk for transcontinental global spread at this time is still low. CDC and the international community's efforts are focused on the containment of disease at source through contact tracing, vaccination, contact monitoring, and conducting more intensive traveler screenings in the affected areas. Despite the high risk of regional spread, the only cases identified outside of North Kivu and Ituri provinces of Eastern DRC in the last 10 months are 3 imported cases identified about 15 miles inside of the Ugandan border in the Kasisi district. These 3 individuals were infected with Ebola in DRC and crossed the border to seek health care in a hospital in Uganda. All 3 cases are epidemiologically linked to a single case in DRC. The Ministry of Health and international partners are closely following the exposed persons. Uganda has proven experience in managing previous Ebola outbreaks and was quick to detect and respond to the recent imported cases. CDC is actively monitoring the situation in Uganda to assess the need for additional travel health precaution. There is no indication of Ebola transmission in Uganda at this time, and we have no Ebola-specific recommendations for people traveling there. However, travelers are still encouraged to stay healthy and safe by observing routine travel precautions mentioned on CDC's Travelers Health website for Uganda, available at www.cdc.gov/travel. Next slide. We believe the risk to the United States from the current Ebola outbreak in DRC remains low, based on the travel volume and travel patterns from the outbreak areas to the United States, as well as the implementation of border screening measures at key airports and ports in DRC and neighboring countries. CDC has issued a level 2 travel notice with recommendations for travelers to DRC, including for U.S. healthcare and aid workers and their sponsoring organizations, to ensure travelers and workers stay healthy during travel and when they return to the United States. I want to emphasize that the risk of Ebola to most travelers to DRC is low, with potential increased risk to those travelers going in or near the outbreak area who may inadvertently come into close contact with people infected with Ebola virus. Family and friends caring for people with Ebola and healthcare workers who do not use correct infection control precautions are at the highest risk. Travelers can protect themselves, and they can do so by avoiding contact with other people's blood or bodily fluids, not handling items that have come into contact with a person's blood or body fluids, such as clothes, bedding, needles, or medical equipment, avoiding contact with bats and non-human primates or blood, fluids, and raw meat prepared from these animals, or any kind of bush meat, or meat from an unknown source. We don't recommend participating in a funeral or burial rites that require handling human remains. And lastly, washing hands often or using hand sanitizers and avoiding touching eyes, nose, or mouth. Travelers and workers should seek medical care if they develop fever, headache, body aches, sore throat, diarrhea, weakness, vomiting, stomach pain, rash, or red eyes during or after travel. Travelers with symptoms suggestive of Ebola should not travel until they have been evaluated and cleared by public health officials. Likewise, travelers with known exposure to Ebola virus should not travel commercially until they are no longer at risk for the infection. If necessary, U.S. travelers can request assistance from the Department of Health and Human Services and Department of State in arranging for medical evacuation back to the United States. For those who work in general health care in a hospital, Ebola treatment unit, those that are involved in burial work or laboratory work in the outbreak area, our recommendations are as follows. We suggest wearing protective clothing, including masks, gloves, gowns, and eye protection whenever you are at risk of exposure to Ebola virus. Practicing proper infection control and discussing options for vaccination against Ebola with your employer or sponsoring organization. Now on that, the DRC Ministry of Health, WHO, and other partners are offering an investigational vaccine to priority populations, such as frontline workers in the Ebola response activities. If you choose to be vaccinated against Ebola, get the vaccine before travel, if possible. The National Institutes of Health has an open-label clinical trial entitled Pre-Exposure Prophylaxis in Individuals at Potential Occupational Risk for Ebola Virus Exposure, or the PREPARE trial, to vaccinate adults and volunteers against Ebola, including deploying healthcare workers or other responders. Study sites are at the NIH in Bethesda, Maryland, and Emory University in Atlanta, Georgia. Upon returning to the United States, notify your healthcare facility's infection control or occupational health professional of your recent travel and self-monitoring activities if you will be caring for patients in a U.S. healthcare facility during your 21-day monitoring period. Next slide. From the beginning of the outbreak, CDC has been in contact with aid organizations, sending US-based healthcare or Ebola response workers to the outbreak area to learn about their response staffing plans and occupational health and monitoring programs for returning workers and to provide recommendations whenever necessary. CDC recommends that organizations sending US-based workers to the areas with Ebola outbreaks ensure the health and safety of those workers before, during, and after their deployment. Next slide. Pre-deployment, we recommend that organizations educate workers about Ebola, travel vaccines, and other recommended prophylaxis, example for malaria, and other healthy behaviors, personal protective equipment, and travel health insurance, including coverage for medical evaluation. During deployment, recommendations include remaining in contact with workers, periodically asking about any symptoms of or exposure to Ebola, and contacting in advance the US state or local health departments that have jurisdiction in areas where workers will be staying after returning to the US. Before response workers depart from the outbreak areas, ensure they undergo an exposure and health assessment before travel to the United States. At a minimum, the pre-departure assessment should include a careful assessment for potential exposures to Ebola, review of signs and symptoms compatible with Ebola, a determination that the worker appears well, and oral temperature measurement. Post-deployment recommendations include remaining in contact with workers for 21 days after they leave the outbreak area while workers self-monitor for symptoms of Ebola. For most workers, CDC recommends self-monitoring with oversight by the sponsoring organization. However, for workers with unprotected exposures to the Ebola virus, CDC recommends monitoring by health officials while in the United States. Other restrictions may also be considered. Health departments have the authority to determine how monitoring will be done in their jurisdictions. Next slide. CDC has developed template tools that organizations can choose to use or modify to help structure the pre-departure assessment. PDFs are available for download on the CDC website. Next slide. Here are a couple of links with resources and additional information covered during today's talk. Next slide. For urgent consultations regarding symptomatic or potentially exposed travelers, please call the CDC Emergency Operations Center, available 24/7 at 770-488-7100. For questions about these recommendations on travel, and particularly for NGO workers, or additional advice regarding pre-departure exposure and health assessments, please email CDC at eocdgmqopschief@cdc.gov, and this address is available via the slide. For general inquiries, please contact 800-232-4636. That concludes my talk today, and I thank you for this opportunity, and I'll turn it back to Jonathan.
Actually, that's exactly what we're going to do. Thank you, Shaw. Thank you, Mary. We're going to transition to our Q&A session now with Jonathan. Can you read the first question?
I can. I want to point out first that we're getting quite a few questions. We have experts with a particular set of skills and knowledge. Some of the questions may be outside of their purview. If you don't get your question answered today, it's probably for that reason, but you can send the question to EPIC, that's EPIC, at cdc.gov, and we can follow up for you with these experts or other experts. Our first question comes from M. Morrison, who asks, does the vaccine provide lifelong immunity?
Hi, thank you. That's an excellent question. So we don't quite know yet, is the bottom line. The vaccines were developed very recently. There are studies that are ongoing to evaluate that very question, though. Thank you.
Thank you. Our next question comes from A. Hager, who asks, how long after the death of a person is the Ebola virus viable?
Yeah, thank you for that question. Another excellent question. So again, there are some studies that shows that the virus, which is an envelope virus, does not survive very long just in the dry environment. So like a doorknob on the floor, the virus may be viable for a couple of hours. However, when the virus is inside something wet or organic matter like a body or vomit or stool, we know that it can last for much longer. Exactly how long, we don't know. Thank you.
And in general, there may be a lot of questions where the science just doesn't have an answer yet. So that's understandable. This next question comes from Karen, who asks, which species outside of bats and primates have been found to have Ebola?
Hi, this is Trevor. I'll take that one. I believe outside of bats and primates, as Mary mentioned in her presentation, bats we believe to be the reservoir host, which means that the virus and the bat coexist and infects the bat without causing harm to that particular species. We do know from previous outbreaks and in Africa that primates and non-human primates are very susceptible to the virus, just as humans are. And so we don't consider those to be hosts. We consider them to be vulnerable populations, more susceptible populations. There have been, some anecdotal evidence or some evidence of the virus being identified in other species, including small antelopes, but we don't believe that to be very widespread. Those to be isolated incidents.
Okay, thank you. Real quick, Stephanie, would you make sure that the correct screens are popping up? So the next question comes from Patrick Lathrop, who asks, is the vaccine safe for breastfed babies? Is the vaccine safe for breastfed babies?
Yeah, so for that, so the data in breastfeeding and in pregnancy is a little bit more limited than it is in people who are not pregnant and not breastfeeding. However, for this outbreak, the WHO advisory committee that advises them on vaccination safety, the SAGE recommendations, has looked at the evidence and has recommended that the vaccine be used in pregnant and lactating women in this outbreak. Thank you.
The next question, I'm summarizing a question from Mayana, who is asking if this outbreak is connected to the previous large outbreak in Africa.
I think if the question is referring to the previous outbreak of 2018 in DRC, the current outbreak in North Kivu, we believe is unrelated to that previous outbreak, that they are two independent outbreaks. And I believe the genetic sequence of the two different viruses from these outbreak from these two different areas confirms that.
Thank you. Our next question comes from Dr. DeWild, who asks, what would be the threshold for recommending vaccination to travelers to Zaire or neighboring countries, but not going in the hot zone?
So as mentioned earlier, this is Shah. As mentioned earlier, really the vaccine is being recommended for frontline workers that are involved in ETU work, general healthcare work, burial work, etc. So at this time, that's our current recommendation, but we suggest that you continue to follow CDC's website for updated guidance. Thank you.
Thank you. I'm summarizing a question from NMQ1, who is asking if it is ever possible for a person to be contagious and asymptomatic.
Hi, thank you for that question. We have no evidence that shows that people who are asymptomatic are contagious. Thank you.
Thank you. Nate Cunningham is asking why there is the belief that transcontinental global spread is not a very likely event.
So this is a good question. The risk is not zero, it's low. So I want to clarify that. And even if we look at the trajectory of the current outbreak was declared 10 months ago. And in 10 months, with the number of cases and the porous borders, we've witnessed 3 cases in Uganda recently, 15 miles across the border. That question can't be fully answered, but what I can tell you is that the majority of population movement mapping that has been done has shown that the majority of people are traveling locally within 100 kilometers, and they're not air travelers. Thank you.
Thank you. The next question comes from Theory Nayatani, who asks, is there a current need for additional workforce support?
Hi, I'll take that one. I think the current outbreak, CDC is working very closely with our international partners, including WHO, other non-governmental organizations, and our Ministry of Health partners and other local organizations. I believe at this time, and unless you're affiliated with one of those organizations, there's not an additional need from the general public or outside populations to assist with this outbreak. And as Shaw mentioned, it's relatively geographically limited, even though the numbers are large. So we don't anticipate any further spread beyond those particular areas at this time. But we're constantly reevaluating and assessing those needs as we go on. Thank you.
Thank you. We've had multiple questions about screening, including screening of returning university students, screening at borders. Shah, previously you had mentioned wanting to address that in general terms. In specific terms, that would be a question for a different set of CDC experts. So if you send specific questions to epic@cdc.gov, we can address them. Shah?
So just to clarify, the question is about what's involved in screening activities. Is that the gist of it?
Just in general terms.
In general. So currently, screening within DRC, there's screening of travelers that's happening within DRC and also the neighboring countries. So there is exit screening that's being done out for travelers leaving by air, leaving the outbreak area. That involves a temperature check and a questionnaire and a visual observation if there are any symptoms in the individual. As travelers leave the outbreak area and arrive into Kinshasa, which is the gateway where the majority of travelers come to the United States, there are entry screened by the Ministry of Health workers. Again, that includes a temperature check, visual observation, and a questionnaire to assess risk. Additionally, we're aware of entry screening activities for travelers that are occurring in Uganda, in South Sudan, and other neighboring countries, Rwanda, Tanzania, etc. So those activities are currently in place.
Great, thank you. Next question comes from Steve, who asks, how long after receiving the vaccine will you be protected?
Hi, thank you for that question. We believe about 10 to 14 days after you receive the vaccine, you should have protective antibodies. Thank you.
A follow-up question, because it's from a different person, but it's in the same topic, asks, what percentage of people after being vaccinated may still acquire the disease?
Hi, so thank you for that question. So we believe that the vaccine efficacy is about 95%. But as I mentioned, if you have already been infected and are incubating the virus and then get vaccinated, the vaccine will not prevent you from developing the disease. So we did see this in studies that were done when the vaccine was used in Guinea in 2014, towards the end of that outbreak. So, but when they looked at individuals who were vaccinated, how many then developed Ebola 10 days or more, that was zero for that study. So we feel that when the vaccine is given pre-exposure, so before they become exposed to the virus, that is very efficacious. When it is given after, depending on whether or not you have already been exposed, that will determine whether or not you will develop the disease. Thanks.
Thank you. I'm going to summarize a question from Ryan Kinney, which is asking if a person, say a family member, has been exposed but is not symptomatic. Should they be quarantined?
So we do. So yeah, the question is, if a family member has been exposed, should they be quarantined? No, that is not the strategy that we've been taking. So because many people can be exposed, but only a small percentage will then develop the disease. So the strategy that they're using in the Democratic Republic is, once you have a case and you identify a contact, so therefore someone who's been exposed to that case, that contact is then followed every single day for 21 days, which is a maximum incubation period. And the idea is that as soon as that person becomes symptomatic with, fever, muscle aches, that sort of thing, that they're then immediately taken to an Ebola treatment center where they can be evaluated and tested. And we know that early treatment can improve survival. So it's good not only for the patient to get early care because it improves their survival, but it also diminishes transmission within the community. Thank you.
Thank you. This question comes from Langilko, who asks, does the vaccine for the Zaire strain improve outcomes for people infected with any strain?
Thank you for that question. So the vaccine that is currently being used is only effective against the Zaire Ebola virus, so the Zaire strain. It does not confer cross protection against any other species of Ebola. And currently, there are no vaccines in advanced stages of development that can protect against all strains of Ebola. Thank you.
The next question comes from Susan Fitzgerald, who asks, what are the current CDC recommendations for U.S. Emergency Department Ebola preparedness, including training recommendations for frontline staff?
So let me, currently, if the question, to clarify, if it is what kind of activities should be ongoing in the United States in terms of preparedness. CDC does have recommendations on its website for planning, training, exercise activities in the United States. We recommend an all-hazard approach, but there are specific Ebola recommendations that were made post outbreak of 2014-2016. Those are the general recommendations. That are the top 10 tips, if you will, on our CDC website that you can follow. But there are not special or specific precautions that are recommended at this time exclusively and specifically related to the current outbreak. These are general recommendations that we all should be doing in emergency response, always planning, training, exercising.
Thank you. The next question is this. Is the virus transmitted via insect bites?
Yes, thank you for that question. We have no evidence at this time that Ebola virus is transmitted by insects. Thank you.
Okay. The next question asks about protection of surrounding countries. And I understand we don't have to go into detail, but there are pretty fair protections for a lot of the surrounding countries.
So CDC has been in close coordination with the neighboring countries that specifically are bordering the outbreak area. And we've been working with them in standing up preparedness activities around the various areas that was mentioned during both Mary's talks and mine. And I think one case example that we can give that our investments are paying off are the current activities and response that happened to the cluster of 3 cases in Uganda, and how quickly those 3 cases were contained, isolated, and vaccination was stood up. So a lot is happening in terms of epidemiology, surveillance, preparedness, border health activities in the neighboring countries.
Thank you. The next question comes from Elizabeth from Oklahoma City, who asks, can bite bats infect individuals, or is there a specific type of bat that transmits Ebola virus?
I'm not sure I understood the first part of the question.
Well, there's 2 parts to it. So part 1 would be, can bite bats infect people? If they're bitten by a bat, are they at risk of acquiring Ebola virus? And then the second part would simply be, does the species of bat matter?
Bat bites, I think. Yes, so bats, yes, technically can bite humans. And I think, as Mary mentioned in her presentation, we don't specifically know what species of bats carry Ebola virus. We suspect species of bats carry Ebola virus, but also, as Mary mentioned, there are 6 different species of Ebola virus. And based on other viruses that are similar, we suspect that it might be possible for multiple species of bats to carry different species of Ebola virus. So there could be many. I think the closest representation that we have, or the closest relative to Ebola virus, is Marburg virus, where we do know the host species is a bat called Rosetus aegypticus. It's the Egyptian fruit bat. And that is a very specific species that carries Marburg virus. It doesn't necessarily bite humans, but I do know from our work in our ecology team, if you do handle one of these bats, it potentially can bite you. And we do suspect that if an infected bat does bite you, it could transmit virus. That's probably not the most likely method of transmission of these particular bats to humans. And as Mary also mentioned, it's most likely through indirect exposure through either the biting of fruit that humans will eat, or other contaminated sources with urine or feces or other bodily fluids from infected bats. Thank you.
Thank you, Trevor. The next question comes from PLI7, who asks if cases are primarily clustered in households, among those attending funerals, or in individuals who visited a healthcare setting or some other group.
Hi, so in this outbreak, we are seeing both. We're definitely seeing people who are transmitting the virus to family members, and that certainly makes sense. You know, when someone becomes ill, it's their family members that are taking care of them. We are also seeing evidence that the virus is being transmitted at healthcare facilities, what we call nosocomial infections. Thank you.
Thank you. Another question that I've seen more than once here, so it may be worth reiterating. The question is, how safe is the EVD vaccine?
Thank you for that question. So the vaccine has been studied in thousands of people at this point in 10 countries in the United States, Europe, and in Africa. We have not seen any severe adverse effects. There are side effects for after you develop the after you receive the vaccine, because as I mentioned, the vaccine is a live vaccine, and so as the after injection, it is common to have some soreness in the arm, as well as some fevers and some muscle aches. But we have yet to see evidence of serious, severe side effects from the vaccine. But as more and more people are vaccinated, we may see other side effects that we have not seen to date. Thanks.
Thank you. Denise Jordan asks if there is a travel ban to DRC.
There's not currently a travel ban. Let me rephrase that by saying that CDC has travel health notices and with 3 levels. Our current advisory is a level 2, which is observing enhanced precautions. That means safe travel, safe passage as you travel. Observe the recommendations of not coming in touch with people that are ill with bodily fluids, with blood, etc. The topics that were covered in the talk earlier.
Okay, thank you. We have a question coming from Lisa Randolph, who has a group traveling to Uganda soon. She says they are not going to be near the hot zone, but wants to know if there would be any reason to seek out vaccination.
So I'd recommend that this group visits our CDC Travel Health website for recommendations for travel to Uganda. Currently, we do not have specific Ebola recommendations for travel to Uganda, just general ones. As you would to any destination that you're traveling, we recommend that you visit our website. Secondly, the vaccine is being offered to those who are responders and frontline workers.
I'm going to summarize a question from Camilla, who asks about how public health workers are doing their job in the face of some security concerns in that area. And I understand you may not be able to answer it very specifically, but in a general sense.
So the workers, there are very few US-based healthcare workers in the DRC outbreak area. And those protections for health, security, and safety are assured through their non-governmental organization or sponsoring organization that they're working through.
Thank you. And I think we have time for one more question. And the question is going to come from, nope, sorry, it's not going to be that question. Is CDC planning on updating the Ebola risk classifications that were used during the 2014 to 2016 outbreak?
If this is in reference to monitoring and movement guidance, currently we have no specific requirements for monitoring and movement. We just recommend that returning travelers self-monitor, and if they're ill, to seek care and let their provider or hospital that they're visiting know about their travel plans. If they're a healthcare worker, to work through their sponsoring organization. And then if there are ever any questions, you can always call us at CDC or email us.
Okay, thank you. And Kelly, it's 2 o'clock now. So, by the way, everyone, very sorry if we're not able to get to your questions. They just keep coming in. So if you send them to epic@cdc.gov, we can follow up for you directly.
Thank you again, everyone. Thank you to our presenters. Thank you for everyone who joined us on the call today. If you have additional questions, like Jonathan said, please do email them. We know that there were several that did not get answered. You can email them to epic@cdc.gov. As a reminder, today's presentation has been recorded and you can earn continuing education units for your participation. Please follow the instructions you find on our website, emergency.cdc.gov/epic, EPIC. The course access code, again, is capital EPIC, all letters capitalized, 0619. And thank you again. Bye.